In a clinical scenario, a physician is often going to rely on visual cues or on things that they can easily feel. So this is where the surface anatomy is going to become quite important and relevant to the physician. So they want to be able to either see things or feel them just under the skin. Now, many of these structures are going to be felt under the skin or palpated, while others can simply be viewed. Let's begin looking at the surface landmarks anteriorly in the upper limb with the clavicle. Recall that the clavicle was one of the two bones involved with the shoulder girdle, and it is going to be attaching from the manubrium medially and laterally out towards our scapula. The point of attachment of the clavicle to the scapula is at the acromioclavicular joint. So a physician would be able to palpate along the superior border of the clavicle until it meets up with the acromion process of the scapula, and then palpate the acromioclavicular joint. Typically, a physician could palpate through the large deltoid muscle and feel the greater tubercle of the humerus, located more laterally, a small depression potentially for the intertubercular groove, and a more anteriorly located lesser tubercle of the humerus. Recall that the tendon of the long head of the biceps is going to pass in that intertubercular groove between the lesser tubercle and greater tubercle of the humerus. So this can be a useful area for the physician to be able to palpate regionally and feel those bony landmarks deep to the thick muscle of the deltoid. As we move inferiorly towards the elbow, a physician is really going to be able to palpate quite easily the two epicondyles of the humerus, the lateral epicondyle on the lateral aspect of the elbow and the medial epicondyle on the medial aspect. Recall that the ulnar nerve passed just posterior to the medial epicondyle, and often if a patient hits the medial aspect, they're going to feel a tingling in their palm related to the funny bone, which is the ulnar nerve. So being able to palpate the medial aspect and see the origin of the forearm flexors and the lateral aspect for the forearm extensors can be quite beneficial for a physician. Moving towards the wrist, we're able to almost always palpate the two styloid processes. The styloid process of the radius is going to be positioned on the lateral aspect of the distal radius, and that's going to limit the ability to abduct or laterally deviate our wrist. On the medial aspect of the palm of the hand, we're going to be able to palpate two structures, the pisiform and the hook of the hamate. So two of the carpal bones are readily palpated near the base of the hypothenar eminence within the palm of our hand. Typically, we're also able to palpate the heads of the different metacarpals on the palmar aspect of our hand. And you can also use the proximal and distal ends of the phalanges to palpate through the different joints of the hand. So surface landmarks and surface anatomy are going to be a useful tool for the physician to help diagnose underlying clinical issues.